For today's presentation, I'm going to provide a background on cardiovascular disease and cardiac rehabilitation in the United States, explain non-traditional models of cardiac rehab, share an overview of how we applied implementation science, frameworks, and principles to design and implement a hybrid cardiac rehab pilot study, and how the data from this study and qualitative interviews laid the groundwork for an NIH-funded RO1 that will launch next year. I hope today's presentation will be both insightful and engaging, and that you'll walk away with some perspectives that will spark your own innovation and collaboration as you pursue your own clinical research. Cardiovascular disease is the disease of the heart and blood vessels and includes numerous diagnoses such as myocardial infarction, which you'll hear that a lot today, which is commonly known as a heart attack, heart failure, stroke, arrhythmia, and heart valve disease. CVD remains the leading cause of death for men, women, and most racial and ethnic groups in the United States. According to the American Heart Association's 2024 heart disease and stroke statistics, it has held this position for over 100 years. The CDC reports that one person dies every 34 seconds from CVD. 1 in 3 deaths in 2023 was due to CVD. One person has an MI every 40 seconds in the United States. Each year, approximately 805,000 Americans experience a myocardial infarction. 605,000 of those were for the first time. CVD is often seen as a diagnosis for the elderly, but when we look at changes in CVD death rate among people ages 35 to 64, the trend is quite alarming. For example, 1 in 5 myocardial infarction patients is now under the age of 40. And on this map, as you can see, the red counties are where places that CVD death rate is increasing in this age group. In total, nearly 70% of counties in the United States are seeing a rise in CVD mortality rates among people ages 35 to 64. One of the ways to treat CVD is cardiac rehab, but it hasn't always been this way. If we look at history, we can see that the initial approach to treating MIs was long-term bed rest. In a landmark paper published in 1912, James Herrick recommended bed rest as a treatment for no less than a month for MI survivors. This included they weren't even allowed to walk to the bathroom by themselves. Some of them were prohibited from walking up a flight of stairs for 12 months. So imagine living in a New York City walk-up and you can't leave your apartment because you can't walk up and down the stairs for a year. In the early 1950s, 2 American physicians challenged this belief and explored the possibility of what became known as armchair treatment, which allowed patients to sit in a chair for 1 to 2 hours a day. In 1968, the Dallas Bed Rest and Training Study reported that immobilization is harmful because of the adverse effects of cardiovascular performance, and they demonstrated the benefits of training, which we all know. This changed the way patients were treated and transitioned post-MI care to ambulation. In the 1970s, structured supervised cardiac rehab programs emerged worldwide. And this program started out as purely exercise and then over time has evolved to become the more comprehensive program that we see today. Now, cardiac rehab is a medically supervised comprehensive program for cardiac patients that includes 5 core components: patient assessment, prescribed exercise training, risk factor management, patient education, which includes nutritional and weight management education, as well as psychosocial support. Cardiac rehab is designed to improve health and prevent future problems through exercise, education, and lifestyle support. Traditionally, cardiac rehab included inpatient, so phase 1, and early outpatient, known as phase 2 care. And today, when we talk about cardiac rehab, we typically are referring to the outpatient program. A full dose of cardiac rehab includes 36 sessions that are generally completed in about 3 months. There's a strong dose response between the number of sessions and the health outcomes of cardiac rehab. So attendance in more sessions produces greater benefits in the patient's overall health. As a program, cardiac rehab is supported by clinical guidelines because it's effective. Studies have found that participation in a cardiac rehab program can reduce the risk of death from any cause and from cardiac causes, as well as decrease hospital readmissions. Cardiac rehab participation also improves functional status, quality of life, mood, and medication adherence. Much of this benefit comes from improved fitness through structured exercise. Cardiac rehab is endorsed by the American Heart Association and the American College of Cardiology as a Class 1 Level A recommendation for secondary prevention. For those of you who are unfamiliar with this terminology, Class 1 recommendations have the highest level of strength and indicate that the treatment or the intervention is useful and effective and should be administered for most patients under most circumstances. The level of evidence score that you see of A indicates that there is high quality evidence. If over 70% of cardiac rehab patients completed the program, as in the full dose of 36 sessions, approximately 25,000 lives could be saved and 180,000 hospitalizations prevented per year. Thus, this is an effective program held in high regard within our field. Despite its well-established benefits, cardiac rehab remains underutilized in the United States. Fewer than 30% of eligible patients enroll in and adhere to a cardiac rehab program. As you can see, utilization has been a persistent gap since the 1990s. This is credited to a myriad of barriers, often due to gaps in referral and enrollment, meaning the patient, did they receive the referral from their provider to attend? And if they did they engage and did they attend the program? Here we can see, this is one of my favorite slides, that among eligible Medicare beneficiaries, the overall enrollment rate is less than 30%. And here in New York, we are the second lowest in our nation for patients to complete one session of cardiac rehab. And I think that's just very concerning. If we're New York, we're supposed to be number one, right? Even among those that enroll, less than 10% complete a full dose of the program. And as I mentioned a couple of slides back, the more sessions that a patient attends, the greater the benefits to the patient's overall health. So patients are just missing out on the opportunity to benefit from cardiac rehab. In our formative work, we found that the biggest utilization gap in our healthcare system was adherence, meaning patients were getting referred, or if they were getting referred and enrolling, they were not engaging and completing the program. This gap is not just due to patients, but also things like staff capacity and space. The dismal uptake of cardiac rehab sparked national efforts to address these utilization gaps. In 2015, the Million Hearts Initiative convened professional organizations, agencies, and patient stakeholders to collaboratively problem solve the barriers and facilitators to cardiac rehab participation. This summit resulted in a Million Hearts Cardiac Rehab Collaborative and an action plan to improve program participation from 20% to 70% by 2022. Outlined here is the roadmap that was developed, which includes concrete strategies and descriptions of how to improve referral, enrollment, and adherence. In 2018, the Million Hearts Initiative and AACVPR launched the CR Change Package, which is a quality improvement tool that offers a menu of evidence and practice-based changes that can help improve referral, enrollment, and adherence. Shortly after, the Agency for Healthcare Research and Quality launched Take Heart, which is a 3-year initiative to test recommended strategies, tools, and resources that were outlined in the CR Change Package. Locally, we have initiatives like the Greater New York Cardiac Rehab and Prevention Collaborative, and we've set our own goals to achieve 70% program participation. Among these strategies is one of the key areas of focus is non-traditional cardiac rehab models. This proposal has been matched with increased evidence and scientific statements supporting the need to implement non-traditional models. However, implementation barriers distinct from the traditional brick-and-mortar models exist, highlighting the need to start addressing potential lags in implementation that we have historically seen with the clinic-based cardiac rehab program. And this all begs the question as to whether we will see similar evidence to practice gaps with non-traditional models as we have historically seen with clinic-based. So what are these non-traditional models? Since the COVID-19 pandemic, an influx of non-traditional models have come about. In traditional cardiac rehab, which is what I refer to as our brick-and-mortar model, exercise sessions take place in person at a hospital outpatient facility or a physician's office. So there, the patient and the cardiac rehab professional are physically together. In contrast, a virtual cardiac rehab session uses synchronous, real-time audiovisual technology to deliver sessions. In this model, the patient, who is typically at home, and the cardiac rehab provider are in different locations but interact in real time during the session. Remote cardiac rehab is delivered asynchronously, so patients will complete exercise independently and their data is reviewed later by the clinician. Programs that incorporate more than one of these approaches are considered hybrid models. There's a wide variability between all of these programs that are offered, and it's really an effort to meet the individual needs of different healthcare systems and different patients. In a recent statement, the AACVPR reaffirmed that all cardiac rehab programs, whether they're delivered in person, asynchronously, virtually, remotely, they must include the full set of the core components to be considered cardiac rehab. In other words, simply offering exercise sessions is not enough. The programs must deliver the entire multidisciplinary intervention. Additionally, of all the different program offerings, it's not clear how implementable they are in the real world. So we wanted to know what was the optimal non-traditional model for our system. And this led us to ask the question, what is the optimal non-traditional cardiac rehab model and design to maximize not only the effectiveness, but also the implementation potential of non-traditional cardiac rehab in a real-world setting? To help us answer this question, we tapped into the field of implementation science. Even though researchers regularly discover new and effective treatments or strategies, these findings don't always make it into routine care, resulting in missed opportunities to improve health. Implementation science is defined as the scientific study of methods to promote systematic uptake of evidence-based practices into routine care. It aims to bridge the persistent gap between research and practice by identifying the elements that influence implementation, we call these implementation determinants, and develop theoretically informed, empirically tested approaches, these are our implementation strategies, to address them. Implementation science employs both quantitative and qualitative methods, often in hybrid trial designs, to evaluate not only clinical effectiveness, but also implementation outcomes such as acceptability, feasibility, and cost. Implementation science places a strong emphasis on theories, models, and frameworks, enhancing our ability to understand what works, how, and why with scientific rigor, reproducibility, and evaluation of the implementation process. Now, I will show you how we applied all of this that I've already covered into the development of Teleheart CR, which began in 2020 as a quality improvement initiative in response to the COVID-19 pandemic. And during that time, you may remember that non-essential clinic-based services, including cardiac rehab, were temporarily suspended. In response, Columbia's Departments of Cardiology and Rehabilitative Medicine collaborated to explore alternative models for delivering cardiac rehab. You may also recall that I said there's a strong dose-response relationship in cardiac rehab, as in the benefits of the program are greatest if the participant completes all 36 sessions. And that in our formative work, we found that the biggest utilization gap in our healthcare system was adherence, that patients were not engaging in completing the program. So for this reason, we wanted to design a program that patients would have access to and adhere to. To guide this effort, we used a 3-step intervention generation and refinement process, which you can see here in this figure. This iterative process was grounded in implementation science and user-centered design, incorporating methods such as qualitative interviews, journey mapping, and user testing. We engaged multi-level stakeholders, including patients, providers, and digital health experts, and healthcare system leaders, which ultimately led to the development of a telehealth-enhanced hybrid cardiac rehab program. We published this process in 2023, so if you want to read more about it, you can scan this QR code. And this process yielded Teleheart CR. which is the first study to apply both implementation science and user-centered design in a mixed methods approach to investigate the comparative implementation potential of a non-traditional cardiac rehab program with standard of care within a real-world hospital setting. And this slide outlines the core design features of the program. I'd like to emphasize that our program combines both clinic and home-based sessions to mirror the core components of the evidence-based practice, such as exercise training, education, patient assessment. For the home-based sessions, we partnered with our healthcare system's digital health team to develop a remote patient monitoring platform that supported real-time audio-visual communication and monitoring between the patient and the provider. We also created theory-informed onboarding materials for patients and providers, leveraging an implementation science framework. To give you a brief overview of this study, we then tested this in a single center, 2-arm, 1-to-1 parallel group pilot randomized controlled trial comparing our teleheart CR intervention with the existing traditional cardiac rehab program that was offered as standard of care. Our study design and operations, such as our recruitment pipeline, outcomes assessments, and intervention delivery, aligned with the existing clinic-based workflows and infrastructure of a cardiac rehab clinic embedded within a large healthcare system. But the traditional and teleheart CR interventions were delivered by real-world cardiac rehab practitioners, and implementation support was provided by our digital health team and our research staff. Throughout the program, we collected data in the EHR system and conducted observations. Upon program completion, we administered post-intervention surveys and interviews. So you might have noticed on this slide and the one before that our program had 24 sessions of cardiac rehab, even though I've mentioned multiple times that a full dose is 36 sessions. Of note, this pilot was launched immediately following the COVID-19 pandemic in 2022. And at this point in time, group-based sessions were no longer feasible, and sessions had shifted to one-on-one appointments. So our research team leveraged the existing workflow of a clinic that had adjusted their standard of care model to work with the same volume of patients by providing 24 one-on-one sessions over 12 weeks. It's understood that this is one of the limits of our study. As you can also see here, one of the study objectives was to evaluate implementation potential. As you can see here, teleheart CR participants demonstrated greater program adherence, completion rates, and program efficiency, meaning shorter program duration and fewer no-shows relative to those in the traditional-based cardiac rehab program. Teleheart CR participants also reported high agreement with program feasibility, acceptability, and appropriateness. Our findings suggest that a telehealth-enhanced hybrid cardiac rehab program may elicit greater program adherence and efficiency than a traditional brick-and-mortar program. This enhanced the potential for future scalability. To supplement the quantitative data gathered in the pilot study, we used qualitative methods, including post-intervention questionnaires and in-depth exit interviews to gather rich patient perspectives on the design and the delivery of the intervention. These methods allowed us to explore not only what worked, but also why or why not, from the patient's point of view. We specifically sought feedback on both intervention-related barriers and facilitators, as in how easy was it to use the product, the perceived benefits, any challenges that they might have had with engagement, as well as implementation-related factors. Did the program fit in with their daily life, healthcare provider support, how usable was our technology? By combining qualitative and quantitative data in a complementary way, we developed a comprehensive picture of the intervention's feasibility and acceptability. To organize these insights, we applied an implementation science framework known as the CFR 2.0 to help us code data into relevant domains and constructs. This approach enabled us to better understand the multi-level dynamics that influenced our intervention's success. It helped us pinpoint what worked, what didn't, and how future adaptations can be improved for broader implementation. This table summarizes the key implementation determinants categorized by implementation science CFR 2.0 domains and constructs. We found that our teleheart CR participants did not view time or resources such as transportation as barriers, while both of these were relevant to traditional cardiac rehab participants. Exit interviews further reinforced that participants valued the reduced travel demands afforded by being in the remote model. Based on these determinants alone, one might consider to refine future iterations of the program to be purely home-based. However, our design feedback revealed specific intervention elements that required refinement, highlighting the importance of balancing convenience with tailored design improvements. When we analyzed our design feedback, we linked participant satisfaction ratings to innovation-related determinants identified through qualitative analysis. We found that participants in the teleheart CR group reported high satisfaction with both the clinic-based and the home-based components. Many emphasized that they valued the blend of settings, describing the hybrid model as flexible and supportive. Based on these insights, we concluded that maintaining the hybrid delivery structure is a strength of the program and should be preserved in future iterations of teleheart CR. However, when evaluating the remote patient monitoring component, participants reported low satisfaction with the devices. Qualitative feedback revealed recurring issues with device functionality and Bluetooth syncing, helping us to understand the root causes of their dissatisfaction. Despite these challenges, participants remained satisfied with the overall home-based sessions and video calls. This suggests that while remote patient monitoring remains a viable and valuable delivery model, the specific tools and materials used that we needed to be refined to reduce complexity and improve the utility of the program. This led us to conduct additional mixed methods research with different stakeholders. As part of that mixed methods research, we conducted semi-structured interviews with patients in both English and Spanish to explore their attitudes as well as perceived barriers and facilitators to participating in cardiac rehab. We also gathered their feedback on the hybrid model design. In parallel, we interviewed cardiac rehab clinicians to elicit their perspectives on hybrid CR implementation. A recurring theme from both groups was the role of digital tools and the importance of giving patients the choice to use their own devices for flexibility and for comfort. Clinicians also raised the important considerations related to staffing and physical space. As I mentioned earlier, the pilot was implemented immediately following the COVID-19 pandemic, when one-on-one care was the standard. As clinics have since returned to group-based care, where they typically have 4 patients per session, clinicians emphasized that any new model should align with their current workflows, including the ability to monitor multiple patients simultaneously. This led us into further intervention refinement and generation of new materials, which were used to build a scalable version of teleheart CR within Epic's MyChart app using the Care Companion platform. The refined model allows us to be agnostic to a third-party remote patient monitoring vendor. It supports RPM device flexibility and is built around a leave no patient behind approach to expand access. It also supports group-based sessions and integrates within the EHR system to improve workflow compatibility, making it more scalable across healthcare systems. And I'm happy to say that we received an R1 to now test this model in a hybrid type 1 effectiveness implementation trial. To recap, this is a roadmap of our design journey that informed the final teleheart CR NIH-funded R01 program design. This study will compare a novel telehealth-enabled hybrid cardiac rehab program to clinic-based cardiac rehabilitation for improving patient engagement, functional outcomes, and health equity. I hope that you walk away from today's presentation with a better understanding of the importance of cardiac rehab. The program is effective, yet poorly attended in the United States and even here at home in New York, which means that patients are missing out on these great health benefits of this program. We took a novel approach of applying user-centered design and implementation science at the early stages. We designed with the end in mind as an innovative approach, taking into consideration real-world settings from the beginning. And by taking this approach, you can be responsive to patient perspectives and refine the intervention starting at early stages rather than waiting until the end and learning what does and doesn't work. I hope that this example inspires innovative thinking and collaborative approaches as all of you go out and pursue your own clinical research work. So thank you all here at ACSM Greater New York for having me today. I'd like to thank my mentor and the Teleheart CR study PI, Dr. Andrea Duran, who's right down here in the front, the clinicians, participants, and research team that were involved in all of the Teleheart CR studies, as well as Dr. Carol Garber from Teachers College, Columbia University, for her continued support and guidance. And I know we got a little bit of a late start, so I'm not sure if we have a lot of time for questions, but I'm happy to answer any questions any of you might have.